The journalists following us on Zoom. Also, big hello to everyone watching us on WHO social media platforms. It's 29 December 2021. My name is Tarik Yasharevich, and I welcome you to this COVID-19 press briefing from WHO headquarters here in Geneva. Today, exceptionally, we will not have a simultaneous interpretation in other languages. We will also not have a captioning, so please make sure that questions are done in English only for today. As every time, we will have an audio and video file being distributed to our media colleagues after the press briefing, and transcript will be posted tomorrow. Journalists who wish to ask questions, please press raise hand icon and you will be put in line for that. Today, here in the room, we have WHO Director General Dr. Tedros. We also have Dr. Janet Diaz, who is a lead on clinical care for COVID-19. With us is also Dr. Sosef Fall, who is Assistant Director General for Emergency Response. Online, we should have Dr. Soumya Swaminathan, who is the WHO Chief Scientist, Dr. Mike Ryan, who is Executive Director for WHO Health Emergencies Program. We should also have Abdi Mahmoud, who is the Incident Manager for COVID-19. With us should be Dr. Ruggiero Gaspar, who is the Director for Pre-Qualification Program, and we may also have some other WHO officials with us in case there is a need to answer some of your questions. With this, I'll give the floor to Dr. Tedros for his opening remarks. Dr. Tedros.
Thank you, Tarik. Good morning, good afternoon, and good evening. 2 years ago, as people gathered for New Year's Eve celebrations, a new global threat emerged. WHO's health emergency system immediately swung into action, establishing an incident management support team to run the emergency response and requesting more information about the reports of a cluster of cases of pneumonia of unknown origin in Wuhan, China. Although we had little information, we had enough experience and expertise to know that this looked serious. Early on, we worked out that beating this new health threat, a new coronavirus potentially capable of spreading quickly around the globe, would require three things: science to both understand the pathogen and find solutions to beating it, and solidarity to share and deliver those tools wisely and equitably. Science, solutions, solidarity. And there were major successes. This includes the rapid development of a comprehensive package of technical guidance on how to ready countries to detect, treat, communicate, and prevent the spread within 2 weeks of the first report of the cluster of pneumonia of unknown cause. The sharing of the genome, which triggered the development of diagnostics within the first 3 weeks of 2020, a multi-organizational supply chain system was quickly set up, which included solidarity flights that collectively delivered personal protective equipment for health workers and medical and oxygen supplies for patients. WHO quickly convened scientists and researchers in January 2020 and regularly, therefore, to develop a research roadmap for COVID-19 that accelerated the science around the virus and the creation of new health tools. These included global solidarity trials on new vaccines and treatments to speed up research and development processes. And WHO and partners created the COVID-19 Tools Act Accelerator in April 2020 to accelerate access to tests, treatments, and vaccines. We deployed emergency response teams to support governments in their times of greatest need. Working with clinicians and practitioners around the world, WHO developed a comprehensive living guidance for the clinical management of COVID-19. A common corticosteroid was found to be effective in cutting the risk of death in those with severe disease in September 2020. The development of new vaccines proved so effective at cutting serious disease and death, they represent a scientific masterclass. The increased level of coordination between WHO and member states is exemplified by more than 3,500 national regulatory authorizations in 144 member states following the approval of vaccines through the WHO Emergency Use Listing, EUL. However, while science delivered, politics too often triumphed over solidarity. While there were 1.8 million recorded deaths in 2020, there were 3.5 million in 2021, and we know the actual number is much higher. This is not to mention to the millions of people dealing with the long-term consequences from the virus. Populism, narrow nationalism, and hoarding of health tools, including masks, therapeutics, diagnostics, and vaccines, by a small number of countries, undermined equity and created the ideal conditions for the emergence of new variants. Misinformation and disinformation, often spread by a small number of people, have been a constant distraction, undermining science and trust in life-saving health tools. In the huge waves of cases currently seen in Europe and in many countries around the world, misinformation, which has driven vaccine hesitancy, is now translating to the unvaccinated disproportionately dying. It's vitally important that the established scientific advisory group for the origins of novel pathogens can develop a pathway for the scientific research, search of pathogens, including for the origins of SARS-CoV-2, and we hope to see progress quickly in the new year. But I still remain optimistic that this can be the year we can not only end the acute stage of the pandemic, but we also chart a path to stronger health security. Building on the successes and failures, we must not only share vaccines faster and more equitably with COVAX and AVAT, we must support countries in manufacturing and rolling them out to everyone. And access to new treatments must also follow. This virus will continue to evolve and threaten our health system if we don't improve the collective response. Right now, Delta and Omicron are twin threats that are driving up cases to record numbers, which again is leading to spikes in hospitalizations and deaths. I'm highly concerned that Omicron, being more transmissible, circulating at the same time as Delta, is leading to a tsunami of cases. This is and will continue to put immense pressure on exhausted health workers and health systems on the brink of collapse, and again distributing lives and livelihoods. The pressure on health systems is not only because of new COVID-19 patients requiring hospitalization, but also a large number of health workers are getting sick themselves. The unvaccinated are many times more at risk of dying from either variant. Omicron is moving so quickly. In addition to vaccination, Public health social measures are also needed to stem the wave of infection, protect health workers and systems, open up societies, and keep children in school. I welcome innovative solutions to reaching vulnerable communities that have not received vaccination yet, because the primary doses are the most important for people to develop immunity. Bottom-up microplanning with strong community engagement and mobile vaccination teams, which have been highly effective in ridding most of the world of polio, are another way to get vaccines to the hard-to-reach. WHO will support countries as they look to improve access to COVID-19 tools and catch up with routine immunization. Mental health must also be treated as a core element of our response to and recovery from the COVID-19 pandemic. At the G7 and G20 this year, I challenged leaders to ensure that by the end of this year, countries have vaccinated 40% of their populations and 70% by the middle of 2022. 92 member states out of 194 missed the 40% target. This is due to a combination of limited supply going to low-income countries for most of the year, and then subsequent vaccines arriving close to expiry and without key parts like the syringes. And in the case of about 20 countries, supply chain and distribution issues are also impacting rollouts. 40% was doable. It's not only a moral shame, it costs lives and provided the virus with opportunities to circulate unchecked and mutate. In the year ahead, I call for leaders of government and industry to walk the talk on vaccine equity, both by ensuring consistent supply and helping to get vaccinations actually into people. Vaccine supply, for now at least, is improving, although the emphasis on boosters in rich countries could cause low-income countries to go short again. I call on leaders of rich countries and manufacturers to learn the lessons of Alpha, Beta, Gamma, Delta, and now Omicron, and work together to reach the 70% vaccination coverage. This is the time to rise above short-term nationalism and protect populations and economies against future variants by ending global vaccine inequity. I want governments, industry, and civil society to work with us on a campaign that targets 70% vaccine coverage in every country by the start of July. I also want to ensure COVID-19 care pathways with new treatments are available in every single country, and to ensure people get on treatment at the optimum time. We need to get tests everywhere. Ending health inequity remains the key to ending the pandemic. As this pandemic drags on, it's possible that new variants could evade our countermeasures and become fully resistant to current vaccines or past infection necessitating vaccine adaptations. The technical advisory groups for virus evolution and on COVID-19 vaccine composition continue to review evidence of the variants and analyze the performance of COVID-19 vaccines against them. Any new vaccine update would potentially mean a new supply shortage. So it's important that we focus on building up local manufacturing supply to help end this pandemic and prepare for future ones. One way to increase production of life-saving tools is to pool technology. WHO's mRNA technology transfer hubs are moving ahead in developing an mRNA vaccine. Recently, the COVID-19 Technology Access Pool and the Medicines Patent Pool finalized their first licensing agreement with the Spanish National Research Council for a serological antibody test. I hope there are many more breakthroughs like this in 2022, including for vaccines and treatments. Sharing technology and know-how, as well as waiving the intellectual property rights around COVID-19 tools, should have happened early on in the pandemic. But it's never too late to come together to do the right thing. In 2022, WHO will work with our member states to build well-financed health systems, strengthen preparedness, and ensure the equitable distribution of health tools. From the new WHO BioHub system, which offers a reliable, safe, and transparent mechanism for WHO's 194 member states to voluntarily share novel biological materials, to the new WHO Hub for Pandemic and Epidemic Intelligence based in Berlin, WHO will build mechanisms to enhance partnership. In this vein, the development of a new binding accord between nations on pandemic prevention, preparedness, and response will be a key pillar. I hope to see negotiations move swiftly and leaders to act with ambition. This is the moment for leaders to banish the politics of populism and self-interest, which are derailing the COVID-19 response and threaten to undermine the response to the inevitable next disease X. While 2021 has been hard, I ask everyone to make a New Year's resolution to get behind the campaign to vaccinate 70% by the middle of 2022. We have 185 days to the finish line of achieving 70% by the start of July 2022. And the clock starts now. If we drive this campaign together, we will all be in a much better place by this time next year. Happy New Year. And Tariq, back to you.
Thank you, Dr. Tedros, for opening remarks. We will proceed to questions from journalists who are on Zoom with us. Just to remind everyone that we don't have a simultaneous interpretation today. So we may try with our language skills here to help, but normally we would do the questions and answers in English today. Please click on a raise hand icon so we can get you in line, and if possible, only one question per journalist. So let's start with Bianca Rotier from Brazilian Global TV. Bianca, if you can hear us, please unmute yourself and go ahead.
Thanks a lot, Tariq. Good morning, good afternoon, everyone. Yeah, first of all, I hope you had a great Christmas, and I wish you 2022 full of health. I would like to ask Dr. Tedros to share an overview of these 2 years in relation to Brazil. We saw many controversial messages, and recently President Bolsonaro criticizing vaccination to children, but the country ends the year with a good vaccination rate. And I also see that Brazilians now are more relaxed, and unfortunately covering the WHO and Europe, I saw that everything we experienced here ended up being repeated in Brazil weeks later. So which message, Dr. Tedros, would you like to send to Brazilians? And just a clarification, Dr. Tedros, you said you expect to see the end of this acute stage of the pandemic next year. So in other words, does it mean that the pandemic won't end in 2022? Thanks a lot.
Thank you very much, Bianca. I understand that you have been close to our building today, so welcome. Let me see if Dr. Ryan is online, as he was quite often answering questions in particular countries. Dr. Ryan.
Hi, Kai. Can you hear me?
Very well, Mike.
Okay, great. And thanks for the question. I think you noted yourself in the question that things had been improving in Brazil over many months. There's been a persistent downward trend in both cases and deaths, and that's to the credit of the Brazilian people and the measures that have been taken, and also the uptake of vaccines. Brazil experienced two very large waves, well, multiple waves of infection over a prolonged period of time. In fact, was a heavily affected country for a very long period. Not only did Brazilians experience that, but many people around the world saw the images of overwhelmed hospitals in Latin America, and in particular in Brazil. But all countries have faced those moments. Almost all countries have faced those moments in this pandemic. And it really is by bringing together the work of the health authorities at the state level and at the federal level, and engaging with communities and getting the word out there about the effectiveness of vaccines, I think has helped stabilize the situation. But you are also right that in many ways the experience in Europe and potentially the experience in North America now, we know the Omicron variant is in South America, is in Brazil. So the likelihood is that there will be continued waves of transmission all over the world, and South America and Brazil are no exceptions to that. So as Dr. Tedros has said time and time again over the last number of weeks, this is time to prepare. It's time to get health systems ready. Even if the virus turns out to be in an individual basis slightly less severe than previous variants, the sheer numbers of cases, as we saw previously in Brazil, can put huge pressure on the health system. So getting the health system ready, we saw the shortages of oxygen, the shortages of beds, all of that can be managed and dealt with now if it's prepared for. And it's better to be prepared. If the wave does not come, then that's okay. That's good news. But Brazil and other countries need to be prepared for a rise in cases. They need to be prepared, as we've seen in Europe, for a rise in hospitalizations, and be ready to face what will come. A focus on getting the most vulnerable vaccinated, making sure all health workers are vaccinated, older persons, people with underlying conditions are vaccinated. That is key. There are still pockets in every country of unvaccinated or under-vaccinated people, and it's really important that people are sought out and people are offered the vaccine again and again in their own environments, if possible, and in a trusting and situation. So with regards to the pandemic, we've been saying this for a very long time, the acute phase of the pandemic that's been associated with the tragedy of deaths and hospitalizations, that can end in 2022. The virus itself is very unlikely to go away completely, and will probably settle down into a pattern of transmission, low level, causing occasional outbreaks in under-vaccinated populations. And we hope that is the end game here. But we're certainly not there yet. This is going to be a bumpy road on the way to low levels of COVID. But we do hope, as the Director General, Dr. Tedros, has said in his speech, that by getting the vaccine equity equation right, by continuing to implement the measures we have at our disposal, by continuing to protect the most vulnerable in our countries and in the world, we can bring the acute phase of the pandemic, the phase of death and hospitalization, to an end.
Thank you, Dr. Ryan, for this. We will move to the next question, and that will be Antonio Prato from EFE News Agency. Antonio, please unmute yourself. We don't seem to hear you, Antonio. let's move to next one. Antonio, we will try to come back to you. Let's try with Anne Galland from Telegraph. Anne, can you hear us?
Hi, yes, can you hear me?
Very well.
Great, thank you, thanks so much. Dr. Ryan and Dr. Tedros, you both talked about ending the acute phase of the pandemic. So is that contingent on the 70% vaccine? Do you think the acute phase of the pandemic won't end until 70% of the population are vaccinated? Is that what you see? And how likely do you think it is that we will move away from this acute phase of the pandemic this year and move into the next stage? Thank you.
Thank you, Anne. I can see we have lots of questions on a general outlook. So, Mike, please.
Well, maybe Dr. Tedros would like to comment, but I can begin. Certainly, yes, we would all like to see the acute phase of the pandemic come to an end. And that is the history of pandemics in humans. The pandemic viruses like flu viruses, the pandemic ends, but the virus stays around. In fact, the virus that caused the pandemic in 2009 of H1N1 is still around, but it's not causing the kind of death and destruction that it did at the time mainly because we've been vaccinating the most vulnerable people. And if you look at the strategies we use in influenza, we don't try to vaccinate everybody against influenza, although it could be a very good idea. But what we focus on with the limited amount of vaccine available is to focus on vaccinating health workers, vaccinating older persons, vulnerable younger people. We vaccinate against the negative impacts of getting the infection, which are severe disease, hospitalization, and death. In that sense, heading to try and vaccinate everybody in the population who could potentially have a severe infection is the primary objective. And that was the objective set with the original idea of having 20% and 40% of the population covered. As Dr. Tedros has said, 92 countries, I think, Dr. Tedros, missed that deadline. And there's very, very much still in a very vulnerable situation with large numbers of people within their countries still vulnerable to severe infection. But not only that, even in high coverage countries, even in countries in the industrialized north that have overall high vaccine coverage, within those numbers lie very, very strong differences in vaccine coverage, depending on your socioeconomic class, depending on your ethnicity, depending on which part of the country you live in, urban versus rural. So there are real differences in vaccine coverage in people within countries as well. So this isn't just about equity between countries, it's equity within countries needs to be addressed as well. The 70% number is really about trying to get to the point where you have effectively your full adult population vaccinated and all your vulnerable individuals vaccinated. That's the situation we would really want to be in. If we're going to both impact the severity of the disease or the impact of the health system, but also have a significant impact on transmission, then the higher the vaccination levels, the more we will have impact on that. There is a challenge. The vaccines don't perfectly prevent transmission, but they do prevent transmission at some level. And you will have to have very high vaccine coverage in order to have an impact on transmission. But if you can get to those higher vaccine coverage levels, you will have an impact on transmission, especially with natural infection as well. So I think there is a strong prospect of getting there. We have to get there. It's not just an issue of equity. It's a real question of getting out of the place we're in. And getting out of where we are requires us to get much higher levels of vaccination. You can call it 70% or 65 or 75, that's a number. But getting to a point where the population at risk of having any form of severe infection or long COVID, getting that out of the equation is the primary objective here, and ensuring that we can also suppress the emergence of new variants through reductions in transmission.
Thank you. I think Mike had already said the key issues. Maybe a few things to stress. On the 70%, we hope that it could end it could help in ending the acute phase of the pandemic. However, the key element here is we have to cover the most vulnerable parts of the population. These are the elderly and people with comorbidity, and also health workers. As you know, many countries who have already high coverage, 70%, more than 60% of coverage, are seeing a substantial number of hospitalization and deaths. And this is happening in the unvaccinated population. And that's why also in my speech, I said we need to have a campaign like the polio campaign, which is house to house, identifying the at-risk group and vaccinating those. You know, the average 60-70% wouldn't mean anything if the most vulnerable is not vaccinated. So when we say 70% in each and every country, if all the at-risk groups, the older, the senior citizens, people with comorbidity, and health workers and others are included in that 70%, then we can see minimized hospitalization and deaths to the minimum, and that could lead us into the end of the acute phase of the pandemic. So as we even speak, those countries who have high vaccination coverage, I think they should, in order to reduce hospitalization and deaths, they have to focus at the risk group who are not vaccinated. And that's why the last 2 weeks, we said repeatedly, the most important the focus should be on vaccinating the unvaccinated or protect the unprotected. That would have a better impact and also help us in making progress towards ending the acute phase of the pandemic. Maybe one thing with Brazil, by the way, with vaccination, I think as far as I know, if I remember, the coverage is already more than 65% fully vaccinated. And the overall situation also looks really much better in Brazil. And to what Mike said, what I would add is, continue with vaccination, especially those vulnerable should not be left behind. But at the same time, it's implementing the comprehensive measures, the public health comprehensive measures. So not vaccination alone, do it all. And I think the situation will continue to be better in Brazil too. Thank you.
Thank you, Dr. Rand. Thank you, Dr. Tedros. We will move to next question. That's Reuters, Stephanie Neberhay. Stephanie, please.
Thank you, Tarek. I wonder, a question either for Soumya, if she's on the line, or perhaps Mike, regarding the change in the Centers for Disease Control in the US, their advice regarding their shortening of the recommendation for isolation time from 10 to 5 days for asymptomatic cases. So wondering if you have concerns on that and what your data might be telling you about how long people with Omicron shed virus or potentially transmit it. Do you have concerns about that new shortened time frame, please, which other countries have started to pick up on too? Thank you.
Thank you, Stephanie. Let's see if Dr. Abdi Mahmoud would like to say something on this. Dr. Mahmoud, please.
Thank you. That's a great question. I just wanted to bring back again why we are doing quarantine. And the main objective has been to always to break the cycle of transmissions. So different countries and different parts of the world are in a different situation. Some parts of the world are seeing a low incidence and able to even push the quarantine from the WHO recommended 14 days to 21. Other countries are finding the balance. So at WHO, what we have been recommending is 14 days, and some countries can shorten that based on the testing that. So there are a lot of studies coming up, but what we have seen more and more countries applying a practical health aspect of what needs to be done, balancing the workforce required and the society and the overall objective, what they need to achieve from containing the virus or making this balance. So I think the US CDC may have more information, but what we have gathered right now is too early to determine in terms of the incubation and the infectious period, but more related to balance in the society, whether you go in the full lockdown or the lesser of the two evil. Coming back again in terms of what we recommend to H1, we have been recommending again, comprehensive risk-based approach and protecting the vulnerable. While the overall part of the health workforce can be relaxed, we need to take care of the long-term care facility, people who are immunocompromised, where one infection can be debilitating and life-risking. So I think that in summary is a risk-based approach, and different countries are in a different situation.
Thank you, Dr. Mahmoud, for this clear explanation. Let's move on, and we have someone we have not heard from before, Sloan Smith, Eyewitness News from Bahamas. Sloan, please go ahead.
Hi, hello, good morning. Can you guys hear me?
Yes, very well. Please ask your question.
Good morning from the Bahamas. My question is, with the global spread of the new Omicron variant, there's been new burgeoning concern that the antigen tests that are currently being used to identify COVID may not be as effective in identifying the Omicron variant. My question is whether who recommends countries to continue using the antigen testing for screening, or should countries move towards solely the PCR testing to ensure accuracy in identifying infections and contact tracing? And with that, Caribbean countries and smaller countries like the Bahamas who use testing for people coming into the country. Thank you.
Thank you, Sloan, and welcome to WHO Press Briefings. Maybe Dr. Mahmoud, would you like to have this one?
Thank you. In terms of the RDA, that RDT approved by WHO under the EUL, we haven't had any studies confirming that. We're aware that FDA has released press that some of the currently in some of the US are not viable. But as of now, our lab colleagues have been very closely working through the TAG-VE, and that under the WHO EUL, the current RDT are able to detect and function that. So it's a multi-layer that the RDT are working, and then another layer of the PCR. So we work closely. If we get more information of the overall, some of countries are using different ones that are not approved by their local approval authorities. But for WHO, the main ones are still functional and able to detect Omicron.
Thank you, Dr. Mahmoud. We will now move on. We have Simon McCarthy from South China Morning Post. Simon, would you please come in?
Thank you for taking my question and for holding these briefings without fail over the past 2 years. Happy New Year. So my question is about the effectiveness of vaccines against the Omicron variant. I know that we've started to see a few initial real-world studies, and I'm just wondering first how important it is to see the real-world data versus just neutralizing antibody studies. And then if you could explain a little bit more about how the WHO may be coordinating or working with local teams who are in a position to do these real-world effectiveness studies, and specifically whether there are efforts to ensure that the data generated for all those that there is data generated for all those vaccines which have received WHO EUL. Thank you.
Happy New Year to you, Simone, as well. Dr. Swaminathan, are you on with us? Could you please answer this question?
Yes. Thank you, Tariq. Can you hear me?
Very well.
And thank you very much for that question. I think it's a very insightful question, because you did ask about, first of all, studying vaccine effectiveness and distinguishing between laboratory-based assays of neutralization of the antibodies and how the antibodies are neutralizing the virus in the laboratory, and the real-world data, where we're actually looking at whether people are getting sick and what proportion are getting sick and needing to be hospitalized or dying compared to what happened with the other variants. And so as we've explained in these pressers before, there are multiple factors that account for vaccine effectiveness. One is the vaccine itself. I think we know that vaccine effectiveness varies a little bit between vaccines, though the majority or all of the WHO EUL vaccines actually have very high rates of protection against severe disease and death, at least till the Delta variant. That was true. The second is biological factors like age and underlying illnesses. And we know in COVID, with all the variants, that the older you are, the more the underlying illnesses and comorbidities, the more vulnerable you are to get severe disease. And the third factor is the time since vaccination and the waning of immunity. And we know that there's some amount of waning, but again, there's more waning for infection against infections. And that's why we're seeing a lot of breakthrough infections now, especially with Omicron, because Omicron does have the capacity to overcome pre-existing immunity, needs higher levels of antibodies and protection. Now, the evidence on Omicron is just emerging, and I think it would be it's still premature to conclude definitively. But I think what we can say is that all of the lab studies are pointing towards a reduction in neutralization capacity. And also what we see clinically is that people who've been vaccinated, people who've had prior infections are still getting breakthrough infections with Omicron. And that's why the numbers that we're seeing around the world today are extremely high, because these infections are occurring in both the vaccinated and unvaccinated people. However, it appears that vaccines are proving to be still protective, because even though the numbers are going up exponentially in many countries, hospitalizations and even within hospitalization, hospitalized people, the need for ventilation, the need for critical care, that doesn't seem to be going up proportionately. This is a good sign, and it's probably indicating, telling us that previous immunity, either due to vaccines or in some cases due to natural infection by the virus due to a previous variant, is providing some protection against severe disease. And this is what we had expected, because immune responses are much more than just neutralizing antibodies. So neutralizing antibodies capture one part of it. And so I think to some extent we are reassured that people seem to have that pre-existing immunity, are protected from getting severely ill, and therefore there's a mismatch, or the infection and hospitalization are the link between the two has been disrupted. However, having said all of this, I think we still cannot predict what this virus is going to do in people who've no prior immunity, either due to vaccine or natural infection. There are a large number of countries with still a lot of people who are not vaccinated. So we still need to wait and see and hope that this doesn't cause severe disease in them. You asked about what WHO is doing, and we have the research and development blueprint for epidemics, the R&D blueprint, which has been very closely following and tracking this. In fact, Dr. Tedros mentioned that one of the things that started very early on in this pandemic was the convening of scientists and researchers, the development of common protocols, the development of benchmarks and standards and target product profiles, working with the regulatory agencies to ensure that all regulatory agencies were harmonized in how they approach new drugs and new vaccines. And thanks to that, I think early efforts by WHO, we are in a position where we have a very good networks, multiple networks of scientists who are working together, working with common protocols, ensuring that vaccine effectiveness studies are done to the same high standards. And while we still have gaps, we do not have the same amount of data that we would like to see on all the WHO EUL vaccines, as you mentioned. But we are working with our regional offices, with our country offices, with ministries of health to put in place those tracking and monitoring systems that's going to give us the data in the coming days. So I think there's a lot going on already. We are planning some more studies that will be rolled out. And then we have the groups of experts that actually critically evaluate all the studies that are being published, because we know that all studies are not of the same high quality. There are many biases, particularly in these observational types of reports. And so I think an important element also is critical evaluation. And then finally, the SAGE, which is a strategic advisory group of experts on immunization, reviews all of that data and makes the policy recommendations, and will continue to do so in the light of Omicron as well. So I'm sorry that took a little bit longer than I had planned, but I just wanted to explain all the different elements and all the different departments in WHO that are working on this. There's the IDB, the immunization department, the regulatory department, the emergencies program, of course, in which the R&D blueprint sits, the science division, and many, many other departments from across the board. Tariq, I'm not sure if Janet or Rogerio or anyone else wants to add to this.
Thank you, Dr. Swaminathan. I don't see anyone else wanting to jump in. So let's go to next question. That's Kamran Kasimov, representing a number of media from Azerbaijan. Kamran was with us since the beginning of pandemic. Kamran, please go ahead.
Do you hear me?
Yes, Kamran, go ahead.
Okay. Thank you so much. Greetings from Azerbaijan. Now for our country is very actual, the booster dose or third dose, because all effective booster dose or third dose against the Omicron stem, because from the February we are going to booster dose in our country, but exactly Omicron stem capture many countries. And what can you say about this point? Thank you so much.
Thank you, Kamran. This is a question about boosters. I think Dr. Swaminathan may say something about that.
So this is an area that, again, the SAGE, the group of experts who advises on policy on vaccines, has been tracking and monitoring, because the need for boosters basically is, again, based on what is the evidence on waning immunity, across which age groups, across which vaccines. And as I mentioned, there is some evidence now that there is some waning that occurs, after 5 or 6 months after the primary course of vaccine has been taken. And essentially, again, this is being measured mainly through the antibody responses. But when we look at clinical effectiveness, when we look at, say, hospitalizations or severe disease, there is a small drop. Again, there is some waning of about, let's say, 8 to 10%. It's a little bit higher in the older age groups, 10%. To take all age groups, it's more like 7 to 8% at 6 months. And this is why many countries started booster programs, because they wanted to boost or supplement the immune responses that their citizens already had. The WHO basically has been tracking the data and the science, and our recommendations could be based on science. But there was another consideration for us, and that's the whole equity issue. And Dr. Tedros has been speaking to this issue right from the beginning. He spoke to it today as well. The fact that there are still so many unvaccinated people in the world, while in some countries, people are able to receive their third dose. There's even talk of fourth dose in some countries. And so we have to balance the need for boosters to push the immunity if it's waning, particularly in those vulnerable groups, against the imperative to vaccinate frontline workers, the elderly, in all countries, not just in a few countries. And so what we're recommending now, and we had an interim statement on boosters that we put out last week based on the advice of SAGE, is that countries can consider this for their vulnerable citizens, their elderly citizens, those we know have weaker immune systems, immunocompromised, people who are at very high risk of infection and very high risk of severe disease. particularly in the light of very infectious variants, that they could consider boosting, but that should only be done when country has actually managed to vaccinate its highest risk group with the primary course of vaccination. And we've just heard that there are many countries, many countries that are still not up to the 40% mark that would have covered the entire vulnerable populations. And so there is need to do both. There is a need to speed up our primary vaccination programs to share vaccines equitably through COVAX, through AVAT, and there is also a need to further protect those that need that boosting. And so we will recommend the same approach that we did at the beginning on how to countries prioritize their populations. Not everybody needs a booster. An 18-year-old who's just had their first course a few months ago certainly does not need a booster. They're at very low risk of severe disease, whereas an 80-year-old in the same country might actually do better with the booster because we know that with age, the immune responses are weaker. And so that's the exactly the high-risk prioritization groups that we recommended at the beginning that we're asking countries to follow. And we're also saying, let's share those extra supplies that we have rather than boosting young people who still have very strong immune responses from their primary vaccination. If we can cover the whole world, then we can think about these future courses and who's going to need it, and when it's going to be needed. Dr. Ryan talked about the future course of the pandemic and how it's going to play out. And we will have to see whether regular vaccines are going to be needed in the future or not, and for which groups. We don't know that at this point. But right now, I think we have to go by the data, and we also have to keep a close look on the equity aspects, because it's not just the ethics, we said repeatedly, it's the epidemiology, the science behind it. We know that if you leave the virus to multiply, as it has been doing now in many countries because of so many unvaccinated people, that ultimately there'll be another variant and another variant. So it's in everybody's interest, self-interest, to make sure that that doesn't happen again, and that we try not to have any more variants of concern after Omicron. We should try, the world should try to do that. Thank you, Tariq.
Thank you, Dr. Swaminathan. Let's move to next question. We can take one or two more. So we have BMJ online, Elizabeth Mahasi. Elizabeth, can you hear us?
Yeah, can you hear me?
Yes.
Oh, brilliant. So I just have a question about countries reducing their self-isolation period. I know Stephanie asked earlier about the US's 5-day rule. Here in the UK, they're saying that people are able to come out of isolation earlier if they get 2 negative rapid COVID test results. I was wondering if the WHO has a view on whether these tests are accurate enough to use for shortening the self-isolation period. And just generally in terms of self-isolation, has Omicron changed anything?
Thank you very much, Elizabeth. I know we have both Dr. Ryan and Dr. Mahmoud online.
Tariq, I can speak to this. Look, at the end of these are, as Abdi outlined so correctly, these are judgment calls that the countries make. What countries are trying to do is to be maximally effective at picking up cases and not having onward transmission, but minimally impacting on people's lives, social and economic and educational lives. And it is always a judgment. The likelihood of someone developing symptoms after 5 or 6 or 7 days goes down exponentially. But there is a possibility of longer incubation periods. But the average incubation period up to now has been around 5 days, 6 days. But there's a range of those incubations. There is some data to suggest that the incubation period for Omicron may be shorter, but there will still be a very wide range around a lower average, even if that average turns out to be lower. And the data is not certain on that because we're dealing with a very limited number of studies and a limited number, again, of individuals. We were talking mainly about younger people. Maybe younger people have a shorter incubation period than older people. We don't know that. So we need to be very careful with interpreting these data. But there's no question, even with all of the previous variants, the incubation period, and most people will incubate and show symptoms or be positive within that first 6 days or so. But there's the chances then of being positive after that and transmitting, their chances of transmitting the disease after that are lower. It is then for governments to make that judgment call of when to allow people out of a quarantine situation with extra testing. The issue with the antigen testing is the antigen testing will tell you whether you're infected now, but the window within which it can pick up the virus is narrower than the window that the PCR test is much more sensitive than the antigen test. But again, the antigen test is very convenient. It's very quick. It can be done at home. It can be done on site. And there are a lot of practical real world advantages to doing that. So again, it's a trade-off. So what governments and systems need to do, and Dr. Tedros is continually saying this, is a multi-layered comprehensive strategy that looks at the data and the science and applies that science in policy that's rational, that's simple to understand, that's consistent, and isn't been changed all the time, every day, where people get confused. People need a very straightforward, understandable, supported system where they know exactly where they stand, what category they're in, how long they need to isolate for or be in quarantine for, when they need to be tested, by whom, which test, and that is all extremely clear. And within that, yes, there are trade-offs. And if people shorten the quarantine period, there will be a small number of cases that will develop disease and potentially go on to transmit when they're because they've been let out of quarantine earlier. But that will be a relatively small number, and a lot of people who won't transmit will also be released from that quarantine. So it is a trade-off between the science and being absolutely perfect in what you try to do, but then having the minimum disruption that you can possibly have to your economy and your society. And governments are struggling to find that balance. And because different countries are in different situations economically, socially, and even epidemiologically, you don't see exactly the same strategy being applied in each country. But I think the most important thing at this moment is we need to be careful about changing tactics and strategies immediately on the basis of what we're seeing in early Omicron data. Oh, it's less severe. Maybe it's not. It's more transmissible. Maybe it is. But we have to wait and see if the vaccines work or they don't work. We have to wait and see. And I think it would be advisable at this point, if we don't see huge shifts, huge moves in reducing control measures for COVID-19, purely on the basis of initial or preliminary studies. But where the data exists, where the data is strong, and we'll continue to review that data for all of these parameters. And we will be doing that again and again in the new year. And we will shift based on any new evidence and new science that's emerged, and we will move our guidance. But again, our guidance is at a global level. Countries apply that at national and local level, and local and national conditions will always, in a sense, determine and impact on how global advice is implemented.
Thank you, Dr. Ryan. Dr. Mahmoud, I'm not sure if Dr. Mahmoud would like to add something.
I think Mike has covered. I just wanted to add that, as we said earlier, we're having two outbreaks going at the same time, pandemic. The Delta that's affecting the elderly population, and Omicron, they're less than 60. So whatever measures the country are doing, finding that balance, particularly the most vulnerable and high-risk population, has to be taken. We know from various studies the shading of the virus has possibly associated with age. So our message has been protecting the vulnerable. So that protection, knowing what Delta is creating the havoc, has to be taken. So we really don't know what's going to happen in Omicron. We hope it becomes the dominant, but how it's going to behave in the next 2 to 3 weeks, it will be very early to make decisions solely based that Omicron will be the more dominant patient. People have withstood 2 years of 24 months of hard things, have a lot of resilience in our populations. If it's explained very well, they can accept. So I think just to echo the point Mike said, that we shouldn't make decisions based on only Omicron as the best case scenario, while we know there's a huge outbreak of Omicron going on in hospitals. Thanks.
Thank you, Dr. Ryan. Thank you, Dr. Mahmoud. We will move to last question for today. We have Kai Kupferschmidt from Science. Kai?
Yes, thank you, Tariq. Thanks for taking my question and for doing this presser today. It follows right on from the last comments. I wanted to ask, we have learned a lot about Omicron in the last weeks. Of course, there's also huge questions. And what we have learned seems to suggest that this is following a slightly different path maybe than Alpha and Delta did. So I just wanted to get an update, given what we've seen possibly about generation time, about severity and so on. What is the view from Geneva at the moment on the threat that Omicron poses? How do you, I know there's a lot of uncertainty, but right now, how do you characterize it?
Thank you, Kai. Dr. Ryan, Dr. Mahmoud, anyone else?
I can begin, then the real scientists can follow me. Dr. Mahmoud, hi Kai, Happy New Year. I think the big question is, and Abdi alluded to this earlier, and I think so did Samia, what we're seeing is this dual circulation. We're seeing a well-established Delta wave that's affecting all age groups and particularly causing a lot of hospitalizations and severe disease in older persons now, particularly under-vaccinated or unvaccinated older or vulnerable persons. And that's causing one a major problem. And vaccines have held up quite well, as Samia outlined, in protecting those individuals. And then we have this emerging Omicron wave, which has primarily begun amongst younger people, probably reflecting social mixing patterns, and has been circulating quite intensely in those younger individuals. It's moving slowly into older age groups now. And I think that's the big question in my mind, is will the virus behavior now looks milder, it looks more transmissible, it looks like it has a shorter incubation period, it looks like it's causing a milder disease, and that's on the face of it, looking at the population it's infecting. But what we haven't seen is the Omicron wave fully established in the broader population. And I'm a little nervous to make positive predictions until we see how well the vaccine protection is going to work in those older and more vulnerable populations, to see whether previous infection or vaccination is going to provide the same levels of protection against severe disease and hospitalizations, or if this virus is inherently less virulent in any case in its own right. And that data will come through the system pretty quickly. We are seeing upticks in hospitalizations in some countries in Europe. But again, it's hard to tease that out in terms of the Omicron versus the Delta effect. So that's where we would stand, Guy. It's that little bit early. I would, really like to be optimistic and say, yes, we would hope into the new year that we'll start to see, as we've seen in South Africa, the numbers beginning to fall away. But again, we're dealing in South Africa with a population with a very high seroprevalence, of background seroprevalence, and a very young age profile. It remains to be seen in the coming weeks. I think we will still see that decoupling from cases and severe disease. I think that will be sustained in Europe. But with the sheer numbers of cases that we're likely to get associated with the Omicron variant, it's just that force of infection and that growth rate in the number of cases per day that will ultimately generate sick people who will need to be admitted to hospital and could potentially die. And I don't think anyone is certain yet as to how this is going to play out. And that's why caution right now with getting exposed, protecting those people in our population most likely to have severe disease, physical protection, vaccine protection, and then going by the public advice in each jurisdiction. I think it's really important over the coming weeks that we keep and suppress transmission of both variants to the minimum that we can until we see what the impact of this virus is in those older and more vulnerable populations. Abdi, you may wish to supplement.
Thanks, Mike. You have summarized. I just wanted to what we had today from our South African scientists during the TAG-VE in terms of that sudden drop that's giving some reassurance to other countries and scientists. There is a major impact on the disruption that happened in terms of the social and population change in December. If you look at the epidemic curve for South Africa last December 22, there was such sharp increase and it went. So December holiday, what happens? The population moving, the middle class going out to the coast and the beaches, and the rural movement. There's a lot of things that can disrupt the transmission. So is that a real fact that the Omicron went down, it's milder, or is a multiple factorial that is leading to the reduction? So in testing, the government has just changed their policy. There's a lot of things. So for me, I think it will be very important to look closely at the two other epicenters, London, which has been publishing excellent data and well appreciation for the UK scientists for publicity, and then New York, the hospitalization, how it is going on. If that trend's going on, and from the modeling, they're saying 50%, we're almost looking hospitalization in London at the 1st of December was 114. The day available data is 374, 3 times increase. In New York, almost double, I think 6,173, 945 people are on mechanical ventilation. So the idea, we all want this disease to be milder, but the population so far it affected is the milder form, that the younger. So how it behaves in the elderly population, the vulnerable, we don't know yet. So I think while we encourage it, but the early results is showing that we need more and more time and to be more cautious and to push down as much as possible and vaccinate those unvaccinated population. As Dr. Tedros said, vast majority of the hospitals today are overwhelmed by people who have been unvaccinated because of the misinformation that's going on. So it's too early. We hope, at least from the biological, we had today in the third VE, also Dr. Wendy from the UK was presenting some biological explanation, the difference between Omicron and from the Hong Kong. It's too early to determine. I think the main factor will determine when it hits the high-risk population, over 60 vulnerable that have not received vaccinated. So it's too early, we're optimistic, but I think we shouldn't overinterpret the data coming from South Africa. And that was the feedback we got from the South African scientists. Thank you.
Dr. Diaz, would you like to add something?
Thanks. I'll just add a couple of words to my colleagues there. And just to agree that it is too early right now, and we still must be cautious when trying to ascertain the severity of Omicron virus infection. We do know that there are some suggestions of the reduced hospitalization coming from some countries, as was already discussed. But we need to know also, of those hospitalized, how many are on oxygen therapy, how many are requiring intensive care or mechanical ventilation, and how many are dying. So we do need to get a better understanding of that spectrum of severe disease in patients infected with Omicron. So what do we need? We need more data. We need robust analysis, and this is a call on countries that are experiencing as we heard, the co-threat of Omicron and Delta. Get an analysis done. Look for, ensure that those analyses take into account the various other factors that are associated with severe disease. That includes age, older age, the chronic conditions, history of vaccination status, history of pre-infection, previous infection. And if we do this in sufficient numbers of countries, then we can start to see whether or not what we're seeing in South Africa is generalizable to other countries. So I think before I finish, it's too early to say, but we are getting more data. And also thanks to the colleagues from South Africa for sharing that data, initial hospitalized data with WHO, which has allowed us to start with our analysis here. And we do ask member states to consider sharing their hospitalized data so we can do that aggregated analysis through the WHO clinical data platform, and that will allow us hopefully to better answer these questions in a faster time with something that's where we have more certainty about what our analyses are showing. So thank you.
Yeah, thank you, Kai. I mean, my colleagues have already said, but just a bit of some angle maybe I would like to say. And it's actually my concerns, also our concerns as WHO. There is this narrative now going on, which is like it's milder or it's less severe. But we're undermining the other side. At the same time, it could be dangerous because the high transmission rate, the transmissibility, could increase hospitalization and deaths. And we have already said that, and we're seeing this. So we shouldn't undermine the bad news, just focusing on the good news. There are both elements here. And in our approach, I think we can make use of how the virus behaves without undermining it. So we shouldn't undermine. There are things that we don't know, and we will know more. But until then, it's better not to undermine. And the tools are the same, by the way. We don't want people to be complacent, saying this is not severe, this is mild, and we have to be very careful in that narrative, because what we see also the other side is more hospitalizations are also seen in some countries, and more deaths. So that's what I would like to add. So there are both sides, and we have to see the bad and the good and what it means. But still follow a comprehensive approach, which really works for Omicron too. So thank you, and Tariq, back to you.
Thank you, Dr. Ryan, Dr. Diaz, Dr. Mahmoud, and Dr. Tedros on this answer to last question from our friend Kai Kupferschmidt. With this, we will conclude today's press conference. As always, we will send out files from the briefing, and the transcript will be available tomorrow on our website. With this, media team is at your disposal.
Tariq, this is Mike.
Yes, Mike, please.
Just one point, because just to, given that we're 2 years into this, Dr. Tedros took the opportunity this morning to, as he does very often, to attend our morning emergency management meetings, which occur every single day, to look at the epidemics around the world. And he came there especially to acknowledge and thank the workers across WHO and amongst our partners for all the work they've done in the last 2 years. And we would like to echo that thanks to all of our partners out there. WHO is nothing more than our member states and the institutions and science institutions and public health institutions that make up, that are based in those member states. But 2 years of using a public health approach, despite the issues and despite the very often attacks, it's been a long journey, and one in which I hope we have stood firmly for science and for evidence and for public health and for fairness and equity. But we could not have achieved what we have achieved, and it's a modest enough achievement in the face of all the tragedy and death we've seen. But certainly that could not have been achieved without the leadership of Dr. Tedros. So we just like at the end of this 2 years to thank him for his leadership, his courageous leadership over what has been a hugely demanding 2 years. And I'm sure he would echo my thanks to all of the staff of WHO and all of our partners who work so hard with you, the media, who are still, in my view, very much a major pillar of democracy and justice worldwide. And I thank you who have reported so diligently the information and the data and the stories of this pandemic over the last 2 years. Back to you, Tariq and Tedros.
Thank you, Dr. Ryan. And on behalf of Department of Communications, I really want to thank all the journalists who have been following us throughout this year, just as well they did all the previous years. And we look forward to work with you again. We wish you a happy new year, media team. What I wanted to say is at your disposal in coming days if you need something from us. With this, I will give the floor to Dr. Tedros for his last words. Dr. Tedros.
Thank you, Tariq. So three things quickly. First of all, I endorse Mike's vote of thanks. Thank you so much, Mike, for thanking our staff. I know, what they have been through, and also for thanking all our partners, including our media. So I endorse the vote of thanks. And then the second part is Our resolution for the new year, and I hope, as I said earlier, you will join us. Please join the campaign to vaccinate 70% of population of all countries by mid-2022. We have 185 days to go. It's possible to do it. And I ask for every citizen of the world to join the campaign and end this pandemic. I know everybody is sick and tired, all of us. And I think this campaign is about all of us. And I hope you will join us. And then the third part is I wish everybody a Happy New Year. And I wish you health and peace and, safety and progress. So thank you so much for all your support. And in the new year, look forward to working with all closely. And until we see you next year, which is in a couple of days, all the very best. Bye-bye.